So our next speaker this morning is Dr. Santosh Patel. Dr. Patel is the medical director of the intensive outpatient program at Emory University, where he serves as a psychiatrist focusing on addiction. Dr. Patel graduated summa cum laude from the University of Georgia, go Dogs, with a BS in both biochemistry and molecular biology. He completed his medical degree at the Medical College of Georgia, staying on to complete his residency in psychiatry, during which time he was chief resident. Also, while in Augusta, he completed his MBA through the Augusta University Hull College of Business. Finally, he completed a fellowship in addiction psychiatry at Emory University. Dr. Patel's research has focused on the identification and prevention of substance use disorders in adults and the development of evidence-based treatment programs meant to improve patient engagement and prevent relapse. Additionally, he has certification in the specialty of sports psychiatry through the International Society of Sports Psychiatry. In 2019, Dr. Patel created a mental health clinic aimed to serve those without insurance and who could not afford care elsewhere. This process involved everything from the design of the clinic layout to creating patient workflow, right down to planning a benefit concert to help secure funding for the clinic. Also in 2019, Dr. Patel created educational videos and associated content geared towards educating primary care physicians on various psychiatry topics to review pertinent diagnostic features and treatment strategies for common problems including depression, anxiety, bipolar disorder, and substance abuse. I'm really excited to welcome Dr. Patel as he brings us his lecture today, Opioid Use Disorder in Pregnancy, How to Use Buprenorphine. Thank you.
All right, thank you guys. Really appreciate being here. Thank you, Dr. Perry, for that very kind introduction. And thank you for everybody for sticking around. I know I'm not an OBGyn, so just tolerating someone who's a psychiatrist talk about something that I think is very relevant to everybody here. So my favorite talks when I go to conferences are things where you can actually learn something, go home, apply it in whatever clinical setting you work in, and I think you'll be able to take at least some piece of knowledge, and I'm hoping some practicality out of the lecture today. So let's get started. Financial disclosures, I don't have any, so that's a pretty easy slide to get through. Objectives for today, I think it's always nice to outline the epidemiology, right? So what's the problem that we're facing? What do the numbers kind of look like? Then I'll take you through and talk about some of the updates in terms of buprenorphine and the prescriber guidelines and how they've changed over time. And then I want to kind of focus on these last 4 bullet points for a little while, really talking about how to identify opioid use in a clinical setting, how to assess for withdrawal symptoms, some of the gestational complications, especially of opioid withdrawal, and then talk a little bit about buprenorphine, right? The pharmacology, the initiation, why there might be some hesitation in providers from using this medication that can be extremely effective in helping this patient population. And the last part is the peripartum management, which I think oftentimes just falls off the edge and can be a very challenging time, especially in this patient population. So let's talk. So looking at the numbers, this slide does a pretty good job of breaking down past year opioid misuse and anyone over the age of 12 in the United States. This was data collected in 2020. The big takeaway is at the bottom here. 9.5 million people over the age of 12 or older have had a past year of opioid misuse. Now, before we go any further, I do want to clarify. So opioid misuse is not opioid use disorder, right? And there's a clarification. And for people that might be confused, I'll try to give a little bit more information later in the slides, but just briefly. Opioid misuse is maybe taking an extra Percocet to try to go to bed, right? Maybe taking more throughout the day, right? Maybe asking for an earlier refill. When it turns into opioid use disorder, you start to see it affect other parts of that person's daily life, right? So work is impacted. Now relationships are being destroyed. Financial problems are starting to occur, maybe even legal problems, right? So just keep that in mind as we go through some of this epidemiological data. I like this slide probably the most out of the ones talking about epidemiology because it helps me dispel some of the myths related to opioid use. Oftentimes when we talk about opioid use, we always start thinking about there's a drug dealer around every corner, right? He's giving my patients these drugs and, I don't know where they're getting it from, but, they need to stop. Well, this graph and this pie chart really breaks down where are these medications coming from. This big blue area, 42% coming from one doctor, right? And there is this idea that these patients are reckless. They're going out, they're seeing multiple doctors, they're getting multiple prescriptions, they're stealing from pharmacies, and they're doing all this other stuff. Well, this pie chart breaks that down. So 1% of people who are misusing opiates actually have multiple providers. The majority of them are getting them from one single doctor. And then the number that are actually stealing is even less. So you got 0.6%. They're actually, illicitly engaging in activities to obtain their opiates through healthcare. Now, this big gray piece is kind of that missing area that nobody really likes to talk about, right? So beyond healthcare, where do these other people get their prescriptions? And the answer is usually from family or friends. They're either given opiates from a family member who sees a person struggling and thinks that they could help out with this medication, or perhaps they take them without asking, right? Sometimes family members are so nice they actually charge for the medication. And then the small slice, right? This slice at the bottom, this red and green area, right? This is what people tend to magnify, right? They overproject the idea of illicit opiate use from drug dealers, from street gangs, and criminal activity, right? So we're looking at 6.2%. Now, that's not to say that it's not an important percent, because what you see often happening in the trajectory of these patients is when this blue area is no longer available, the doctor says, no, thank you, I'm not going to keep refilling your Percocet for you. And the family member runs out, the last option is this green area. So you do see in the trajectory, they go from healthcare, maybe to a family member, but oftentimes ending up trying to get their medication through illicit means. All right, let's switch gears, right? So I said there is a difference between opioid misuse and a substance use disorder. So this slide breaks down the actual substance use disorder. This talk is focused a little bit more on opiates and pain relievers, so we'll just skip down these three big bars, right? Alcohol, all illicit drug use, and marijuana, and talk just about that pain reliever use disorder, which is 2.3. This survey actually separated opiates out into two parts, right? So pain relievers being pills, but then they wanted heroin separately. Traditionally, opioid use disorder actually includes both. So not only do you have 2.3, but you have maybe around 700,000 people who have a heroin use disorder. Right? So we're looking at about 3 million people across the country suffering with opioid use disorder. Now let's put these numbers into context, right? So I've been giving you single year values, right? And maybe some of these numbers are like, wow, that's very impressive. But sometimes it doesn't really matter until you see it in relation to annual data, right? And this graph specifies for women and also breaks down age groups over time, right? And it doesn't take too much effort to see that, big bars in the early years, small bars in later years, that's good. We like that, right? And we also like that younger people are much more proactive at not using some of these substances. So we see in 12 to 17-year-olds, maybe in 2016, there was a 0.9% increase in use, and now we're down to about 0.5%. Same thing in 18 to 25-year-olds. Early years, we saw, over 1% increase annually. Now we're seeing close to around 0.7. So that's always nice to see. It's always a positive trend. Older generations is kind of a toss-up. They're up some years and then down some other years. So we'll keep working on that. Another graph that might, provide some relief in regards to prescription use, right? So this is looking at the trend of pain reliever misuse from 2015 to 2020. And again, it breaks it down by age, depending on the shape of the line, squares, triangles, circles, and different shapes. So, the general trend is still decreasing over time, right? So more positive news. And even more positive news, right? So that last slide talked about all prescription pain misuse. This slide talks about new prescription misuse, right? So when we see people who are initiating pain reliever misuse, we also see a downward trend, right? Either they're staying flat or they're decreasing depending on that age group. So another positive thing to kind of, say that things are looking better. And, we look at this data and there's a lot that goes into it, right? A lot of education that goes into it, right? There's, the conception of some of these medications being labeled as more risky, maybe FDA taking more of an active approach and changing the drug labels. There could be legal and policy changes that also influence this. And there can also be, education that starts earlier. Where we have not made progress, and I think some of the bad news is that the ultimate consequence of opiate use, substance use, of course, is death, right? That's the final thing that we always want to see improve over time. So overdoses have continued to increase. And just like there's a lot of things that go into the decrease in misuse of some of these things, there's a lot of things that go into overdose. I mentioned one thing, and I just want you to think about it. When these policies are put in place, when the PDMP says that no more doctor shopping, now we're going to give, red flag alerts for prescribers who are, doing 2 or 3 prescriptions of these medicines too soon, right? That makes prescribers very hesitant to continue to supply these medications, and it forces people to go down avenues that they traditionally would not use. And the number of overdoses from illicit substances obtained from drug dealers and things like that is escalating, and the number of counterfeit pills out there is escalating. So the number of overdoses as a consequence is also escalating. Georgia-specific numbers, about 1,700 overdose deaths in 2021, specifically related to opiates. So it could have been just opiates, it could have been opiates plus alcohol, opiates plus benzos, or any other form, but that person had opiates in their system. And then nationally, we've seen a 17% increase, and then in-state, we've seen a 37% increase in 2021 over 2020. All right, so a little bit of the epidemiology as it relates to pregnancy, right? So 2019, there was this self-reported data from 20,000 plus women across the country. 7% claimed that they were using prescription opioids, and 2% said that they were either getting them from non-healthcare sources or using them for other things besides relieving pain. So if we're thinking in-state, I found this number from, I think the CDC tracked some births. So in Georgia in 2019, about 125,000 births. About 2% of those would be about 2,500 people in the state of Georgia, roughly, right? So this is all estimations and mathematics, are probably misusing opiates. So if you think about your own practice, I assume that maybe the percent of people is probably close to around that 1 or 2%. Now, I think this is unfortunate because I could not get the number of pregnancies in 2019. So we already know that this population is a much higher risk of miscarriages, complications, and not really getting all the way through to births, right? So I imagine that this percent might be, or this number overall might be a little bit low. All right, moving on from the epidemiology. Why does it matter to you, right? I think it's important, and I only started giving these talks to non-psychiatrists after April 2021, because there was a change that went into effect that anyone can prescribe buprenorphine now. You don't need a long, drawn-out training process. All you have to do is jump on this website at the bottom here, say that you're interested in helping out. They'll give you, a pamphlet you can read about. You can refer to the slides. I'm going to go through exactly how to do it step by step. But anyone can do it. And it even lists out all of the clinical specialties and, positions that were allowed to start prescribing buprenorphine. Now, like I mentioned, they do put a little bit of restriction on this. So 30 patients at a time, right? And I can tell you, 30 patients at a time might not sound like a lot, but when the percents are 1 or 2%, 30 patients is probably enough for the majority of non-psychiatrists, non-addiction people who are trying to treat opiate use disorder. So take time, maybe, if you get a chance in between breaks, really check out this website, right? Because this is what applies to you, right? This isn't a talk where it's like, you refer to somebody else. No, this is something you can do, right? All right, so if you want to do more than 30 patients, you still have the option to do that, right? You don't need to be an addiction psychiatrist to prescribe this medication. You do have to go through the training, 8 hours for physicians, and then APPs, it's a 24-hour program. I think it's broken up into 3 days. You can do live sessions. It's 8 hours a day, or you can even break it up into 5 days, and it's a little bit less over time. One thing I did find while putting these slides together, interestingly enough, there's a HRSA grant that funds people who work at rural health clinics and federally qualified health centers that if they go through the full training, they can actually get reimbursed up to $3,000 for that. So, and that's each individual within a practice. So I don't know how much that would apply to the people here, but just something to think about in terms of an incentive. If you want more info on that reimbursement, I left the link down there as well. So now that you know that you can do something, let's start talking about how can you make a difference, right? So everything from here I'm hoping is something that you take away and think, I can start applying some of this stuff, and hopefully if it's not all of it, I can reach out to Dr. Patel in Atlanta and maybe he can walk me through the rest of it because I forgot, right? So identifying opioid misuse, of course, I'm sure many of you are already familiar. ACOG recommends universal screening for substance use at the first prenatal visit. There are a lot of tools out there, a lot of patient questionnaires that can help you through this and make it very simple, right? You just give a form to a patient, they fill it out, you look at it, and then you decide, well, does this person need extra time committed to this problem, or can they just kind of move along their regular day, right? The one that I found to be most interesting and probably one of the more well-rounded ones was this 5P screening tool. So it's a 5-question screener. And the interesting thing that they do, and I'll show you the screener itself, is they go through and they ask progressively personal questions about substance use. So unlike a lot of the treatment and unlike a lot of the kind of clinical settings in which we see opioid users, it's very confrontational, right? Are you using drugs? How much drugs are you using? When are you using them? Are you using them around your baby, right? So this takes the gas off a little bit and allows the person to actually think through, process it, start to become a little bit more comfortable with answering these questions, and hopefully be a little bit more truthful. And the nice thing about this screener, it's also effective not only for prescription opiate use, but also alcohol, illicit drugs. Through validation studies, we've seen sensitivity close to 0.8, so a pretty good screener. Specificity not as great. So just because the screen's positive, now you have to do a little bit of work and kind of tease apart some of the things. The screener itself, like I mentioned, progressively more personal questions. So it starts with parents, right? Did any of your parents have a problem with alcohol or drug use? Then it goes to peers. What about your friends? Do they have any problems? Then it talks about your partner. Then it talks about your past. And then it moves on to what's going on right now. Are you having any problems? Right? And these columns, they break down. If a person answers yes or no, they put them in this specific lane. And then you can actually verify and risk stratify based on the lane that they end up in, right? So what do you do next? So you can either review the risk, if they're low risk, and then review the substance use, maybe set up some healthy goals, if you need more of a safety plan or a referral to a specialist, or even consider their emotional health. So these two questions, the ones about emotional health and violence, aren't traditionally included in the 5 Ps, but you can modify it to maybe ask a little bit more, be a little bit more thorough. This is a busy slide, and it's intentionally busy because opiate use disorder has lots of criteria. And I want to make it as simple as possible for you, right? So instead of focusing on 11 different criteria, trying to figure out the numbers and think back to, DSM and how many of this do I need in which domain, just remember 4 things, right? When you start seeing someone and you suspect that they're misusing opiates or they have an opiate use disorder, if you can ask 4 of these questions, and if they screen positive for 2, even if they screen positive for 1, there's a high likelihood that this person is probably in the opiate use disorder category and no longer in the opiate misuse category. So let's go through, let's just talk a little bit about them. So impaired control, right? That makes sense. I'm using too much, I don't want to use one, but now I decided, maybe I will, right? I had set boundaries, but I can't stick to them. Pretty simple, impaired control. Failed responsibilities. Ask about work. Are you missing deadlines? Ask about home life. What about your partner? What do they think? How are you doing at home? Are you fulfilling your responsibilities? Hazard use, right? Using when you know you shouldn't be, right? I'm supposed to be taking care of my 2-year-old, but I'm inebriated with Percocets, right? Or, of course, using and then driving, or using at work when you should be, focused, right? You need to be there. There's the idea of physical dependence. Is this person going through withdrawal, symptoms after stopping, right? Or are they experiencing tolerance where they're having to increase their dose every so often? Or are they even experiencing cravings, right? Desires to use that are forcing them to kind of ignore their other responsibilities. So don't worry too much about the full criteria. Focus on these 4. Let's talk about opiate use during pregnancy. So I just bolded the big takeaway here. People who are misusing opiates, people with opiate use disorder, they have increased risk of several different things as it relates to pregnancy. First is fetal growth restriction. You can get placental abruption, preterm labor, intrauterine passage of meconium, and even fetal death, right? Complications are hypothesized because there haven't been significant studies done to look into, what is the cause behind this. But a lot of the research that has been done has shown that withdrawal from opiates has a very negative impact on the exposure of some of these substances to the fetus, right? If you've ever seen someone go through opiate withdrawal, it's a very empathetic, almost a sympathetic situation, right? This person is struggling right in front of you. They're having physical symptoms. They're sweating uncontrollably, tremor, their anxiety is skyrocketing, they're having goosebumps, they're having diarrhea, all sorts of different things, right? So imagine that happening to a fetus that's going through opiate withdrawal, right? One of the big things that we also know, especially with illicit pain medication use, is there are lifestyle issues that arise, right? And these things, are tough to talk about, but they're true, right? Things like prostitution, theft, violence, exposure to STIs, victims of violence, and even legal consequences. So all of these things, of course, they have negative outcomes on pregnancy, right? You can't tell me that, someone who's in jail for part of their pregnancy is going to have good outcomes compared to someone who's not. I put this slide in here because I've noticed that when I go to a talk, there'll be 1 or 2 people that ask me the question, like, why is buprenorphine different than just giving someone heroin, right? Am I their new drug dealer? Am I just replacing one chemical with another chemical? So for that, I put this slide in here because, benefits of buprenorphine are much more than just looking at pharmacodynamic strategies, right? We're looking at outcomes. And the outcomes that we see when a person is on a stable dose of buprenorphine versus someone who is out there struggling to find their heroin are substantial, right? And I listed all of them, and, I don't need to go through all of them, but I bolded the one that I do want to focus on, right? The use of buprenorphine decreases all-cause mortality. So that slide where I'm talking about overdose, that's that patient out there who's struggling to find their opiates, right? Who has no avenues, and they're kind of down to their last straw, and they're just using whatever they can get their hands on. Let's talk about buprenorphine specifically here. So buprenorphine is a little bit different in biochemical structure than what you might expect from things like methadone, Percocet, Vicodin, hydrocodone. All of these other things are full opioid agonists. Buprenorphine is a partial agonist. And there's a nice graph that I'll show you a little bit later to help explain the difference. But just remember, biochemically, it is slightly different receptor activity than your full agonist. It's in the same class, sure, but it works in a different way. Because it's a partial agonist, it has these properties. It's less reinforcing. It's easier when you are withdrawing from it. There's an overdose ceiling effect, where it takes much more to produce these types of overdoses. And then there are studies that have been shown that using a partial agonist like buprenorphine results in less severe neonatal abstinence syndrome. I'm not going to say it's zero because it's still there. It's still an opiate, but it's significantly less. A little bit about the biochemical properties. Onset to action, about 30 to 60 minutes. You'll see improvement in withdrawal symptoms, peak effect within 1 to 4 hours, and then the duration of action can last up to 2 days, especially if you're taking higher doses at a consistent time interval. This is the graph that I was mentioning, right? So we have our full agonist, methadone up top, and it doesn't have to be methadone, it could be anything. And you see how the mu receptor intrinsic activity is impacted by this medicine. It's also this idea that more of this medication and more of this activity can result in brainstem depression, right? And that's where you get this kind of hypoxia, overdose type deal where the person's not breathing, they're not responsive, their pupils are pinpointed, all this other stuff that goes on. Well, buprenorphine never hits that threshold, right? We see as a partial agonist, it's got a ceiling type effect. So at most, you're looking at around 50% impact on these mu-opioid receptors. And that's significant, right? Because you can avoid all of those negative consequences that you see with things like full agonists. Naltrexone down here is a complete antagonist. I didn't talk too much about that in here. There's still some studies going on talking about safety and what it looks like in pregnancy and things like that. So maybe I'll be back in the next couple of years and talk about that. But for now, just focusing on buprenorphine. How does it come? How do you prescribe it? What do the dosage look like? So buprenorphine is usually prescribed in a combo pill with naloxone. The brand name of that is Suboxone. Buprenorphine monoproduct is out there, and you can prescribe it. And then there's these other formulations, Subzolve, and I've never even used that last one, but they're out there, right? So pretty much what you're going to be using is that buprenorphine naloxone. Why is the naloxone in there, right? So the naloxone is kind of a harm reduction agent in that it prevents some of these negative behaviors. So because it is a partial agonist, because it is still an opiate, someone can misuse it, right? They crush it up, they melt it in water, heat it up a little bit, and they can inject it IV. It's absolutely possible to do that. But adding the naloxone prevents that, right? Naloxone itself is not bioavailable when you take it orally, right? So with these medications, the buprenorphine formulations, all you do is you put the tablet in your mouth and it dissolves. When you do it that way, naloxone is not active. It's not absorbed. It's not really effective. But when a person crushes it up and injects it IV, now all of a sudden the naloxone is there, and it prevents the misuse potential of this medication. So 5 years ago, there were a lot of studies out there talking about, is the naloxone okay in pregnancy? Should we be using it? Should we be using the combo pill, or is the mono product of buprenorphine alone the preferred thing? Well, a lot of studies more recently that came out, this one back in 2020, found that really there's no difference, right? There's no adverse outcomes between using the mono product and the combo pill. So my advice to you is that if you're thinking about using this, or if a patient is on it, use the combo pill, right? Because of that deterrent activity I just talked about with the naloxone. Another study, same results. This one was done 2020 again, just comparing buprenorphine versus buprenorphine with naloxone. Same result, right? So they compared the monotherapy and the combined therapy. Both were acceptable pharmacological treatments for opioid use disorder in pregnancy. When you would and when you would not use buprenorphine. So there's really only two contraindications to this medication, right? And they're the same contraindications that you would see with most medications. If someone is allergic, don't use it. Simple. The other one, maybe a little bit more effort on your part to ask, but if a person is going to undergo a procedure in the immediate future, like tomorrow or next week, and they're going to be needing pain control through full agonists, then it's probably worth waiting until after that to start them on Suboxone. Precautions to use, other things that you should be mindful of, concurrent use of other depressants, including alcohol, other opioids, and benzodiazepines. Again, there is an opioid, kind of that overdose ceiling effect that I talked about, but you still want to be mindful about not combining these medications with other depressants. There is this idea that you can precipitate withdrawal. If a person is on a full agonist and you give them buprenorphine too soon, then maybe they'll go into withdrawal, right? And just be mindful of that. And we'll talk a little bit more about that. And then, of course, these medications, buprenorphine itself is metabolized through the liver. So just be mindful that, if someone has significant liver dysfunction, and oftentimes you do have to consider that because this population is high risk for things like hepatitis C, HIV, and other things. So let's talk about starting buprenorphine, okay? Now, this will be more of a step-by-step thing, and I really want to focus in and try to explain how easy it is to do it. I really don't need this many slides to tell you how to start it, but I think it's important for providing confidence and making you feel comfortable, right? So Ideally, just wait 12 to 24 hours since the last opioid use. If a person's using a long-acting opiate, things like methadone, wait a little longer. You would want to wait until the person is starting to experience some withdrawal symptoms, right? And the way to monitor withdrawal symptoms is to a tool that we call CALS, and I'm sure maybe some of you have heard about this, right? And the score you're looking for is greater than 12. And we'll look at the CALS in a little bit and look at the symptoms that it covers. Once you get the patient to where they need to be in terms of that withdrawal window, you want to start a low dose, minimize the risk of precipitating more withdrawal, and you also want to make sure that when the person is given the buprenorphine, that they're told that if you take it too soon, you might have a worse experience with it. And oftentimes when you tell patients that, they get very, very diligent with the medication, right? And oftentimes they might even err on the other side, where they wait too long and they experience some withdrawal symptoms that are probably more significant than they needed to, right? And I guarantee you, if you're at this point, you're starting buprenorphine and you talk about opiate withdrawal to a patient, they're going to, Doc, I already know opiate withdrawal. I've already been there. I already know what to expect. I know how often it happens. It's usually, 10 hours in and I'm starting to feel X, Y, Z, right? The CALS can help you with that, determining what symptoms are related to opiate withdrawal. And I'm not sure how well you can see that here, but it does break it down into different categories, right? So we look at, vital signs. We look at different physical responses, sweating, restlessness, pupil size, of course, is in there, bone and joint aches. And there's also this kind of idea of, mucosal excretion, whether it's through tears or snot or whatever else it might be. There's yawning. Of course, anxiety and irritability, and then goose flushing, where there's that piloerection, right? So the hairs are standing up on end type deal. And the scale is relatively easy to define because it's not just 1 through 4, but they actually break it down. What does 4 mean? What does a 2 mean, right? What am I looking for? So it makes it a lot easier. If you're going to tell the patient to do it themselves at home, which is a very practical and easy thing to do, you can use a scale called the Subjective Opioid Withdrawal Scale, right? So at this point, the patient is a little bit more in control. They're not in a clinical setting, right? So they can go home, they can take this, and they can, say how true each statement here is. And again, at the bottom, it kind of breaks it down for you. 1 to 10 would be mild withdrawal, 11 to 20, you're looking at moderate, and 21 to 30, more moderately severe, and then anything above 30 is pretty significant, pretty severe. And we always want to start in this kind of moderate range with the buprenorphine. So day 1, patient comes to you, day 1, you have determined that this person has a problem with opiate use disorder. You review the vital signs, you grab a urine drug screen, and you confirm that at least they're in moderate withdrawal, right? So CALS or the SALS or whatever scale you might be using is somewhere in that moderate range. The first dose that you want to give, 4 milligrams. I always recommend, don't go too low, you might not see much benefit. Don't go too high, you might precipitate too much withdrawal. So 4 milligrams, sublingual. They just drop it on their tongue and it's gone. Wait 60 minutes and then reassess the withdrawal symptoms. 3 things are going to happen, right? Either the withdrawal is going to improve significantly, either it's going to worsen significantly, or there's going to be no change, right? So things get better, things get worse, or there's no difference. So what do you do for each one? So if withdrawal symptoms are the same or mildly improve, you give them another 4 milligrams, right? If withdrawal symptoms have resolved and they're not experiencing anything, you wait until the medication maybe starts to leave the patient's system and reevaluate in 6 to 12 hours. And if they do reoccur at that point, you can give them another 4 milligrams. And then if withdrawal symptoms are significantly worsened or there's concern for precipitated withdrawal, and usually when we talk about precipitated withdrawal, it's not CALS going from 12 to 15. We're talking about CALS going from 12 to 40, right? It's a significant change. So at that point, you just stop it, right? Maybe you started too early, it's okay, you'll start again tomorrow. One thing to keep in mind is that no one's going to die from opiate withdrawal. Unlike alcohol withdrawal, unlike benzo withdrawal, opiate withdrawal is uncomfortable and it's terrible, but it's okay, you'll restart tomorrow. I recommend never exceeding more than 12 milligrams on day 1, right? Just keep a lid on it, you can always increase it tomorrow. Let's talk a little bit about precipitated withdrawal. We've mentioned it a couple of times. So It's definitely caused by starting too soon in the withdrawal process. It's less likely to happen at low doses, like we mentioned, and it's self-limited, so it improves. Usually within a couple of hours, that precipitated withdrawal is back down. Supportive medications can be very effective for precipitated withdrawal, right? So depending on the symptoms they're experiencing, you can treat that. If it's nausea, if it's vomiting, if it's diarrhea, if it's cramping, treat the symptom, right, while they're trying to excrete some of that buprenorphine. And then if absolutely necessary, and you want to break the withdrawal, you can always give a full agonist, right? So that's always in your back pocket. You can always think about doing that. Why does precipitated withdrawal happen? A lot of people, they say, oh, it's because the naloxone's in there, right? It's a full antagonist, and that's what's causing the withdrawal. That's not true, right? This graph we're getting back to, right? So imagine a person is on a full agonist, and they get started on buprenorphine. What you're doing essentially to the receptors is you're dropping them from 100 to 50. Buprenorphine binds tighter to the mu-opioid receptors than most other full agonists. So it's going to kick off that heroin, it's going to kick off that Percocet, whatever else that person might be taking, and it's going to force them into lower receptor intrinsic activity, right? And you kind of see this in this little cartoon to the side. The heroin's getting kicked off and the buprenorphine's getting stuck in, and that's why this receptor activity decreases. Where we'd like them to be is somewhere below that 50% threshold. So that's why we say wait until they're in mild to moderate withdrawal, right? They'll be under the curve, so they'll be at maybe 35% receptor activity. And now when you're bumping them to 50, it's actually helping them, right? So you're in the right window to start the medication. All right, day 2. So they finished day 1. They come back. Maybe they're still having some lingering withdrawal symptoms. Feel free to increase the medication by 4 milligrams every day. Don't go too fast. Allow the medication some time to work. But increasing by 4 milligrams is a pretty safe approach. Splitting the dosing can also be effective, right? So if someone comes to you and says, hey, my symptoms are worse in the morning than they are at night. Well, okay, we'll just cut the dose in half, take half in the morning, take half at night. Let's see how that works. Target dose, right? So how do you know when to stop? So you want to stop once the withdrawal symptoms are gone, but you also want to stop when there's no more cravings for opiate use, right? And cravings are a tough thing to describe to people who've never had them, right? Cravings are pretty much, this thought comes to my head, I want to use opiates, I'm going to drop everything I'm doing right now, I'm walking out that door and trying to find a pill to take, right? That's cravings. And then total daily maximum shouldn't exceed 24. I mean, if you want to go over, there have been case reports where you can go over, probably shouldn't. 24 is usually effective for most people. Now what do you do, right? So you got them on a good dose, you're doing well, so routine appointments, right? After you reach the target dose, prescription lengths can be increased from weekly to every 2 weeks to every 4 weeks. You do want to make sure that they do have naloxone at home, right? Even though there is an overdose ceiling effect, just being mindful that if they do start to combine it with maybe their doctor's benzodiazepine or their alcohol or something like that, overdose potential exists, right? It's much lower than a full agonist, but it's still there. You also want to make sure, you're doing regular interval urine drug screens, and that can help identify either adherence or a return to use of opiates or something in between. And then typically in the 3rd trimester, dosing for buprenorphine usually needs to be increased. And I think that's probably more of a physiological impact. We've seen that, 1st trimester, 2nd trimester, you just continue whatever dose you might be on, or they need significantly lower doses. But then 3rd trimester rolls around and they might be talking about more cravings, right? I really want to use opiates. So just go up on the medication. It's a very effective way to deal with that. After delivery, right? So we're talking peripartum period, and I feel like this is probably the highest risk of relapse. Oftentimes they're struggling with so much other stuff, right? Insurance is going to get cut off soon. OB provider's not going to be my doctor anymore. I don't really have anybody else to see. So just be mindful, right? So after delivery, relapse rates are highest. And then, abrupt tapering or discontinuation of this medication increases that risk even more, right? It's kind of like what we talked about. When you take away the person's medication, what are they left with? What avenues do they have, right? So the risk of relapse increases substantially. So the recommendations, and ACOG actually made some of these recommendations. They recommended continuing buprenorphine through the postpartum period until the stress of a newborn has stabilized. Now, it's a very generic recommendation. It's like, when does that happen, right? Is the baby 2 or 4 or what? So, take that for what you will. But I think it's important to consider, right? With this medication, you can absolutely breastfeed, and it's actually encouraged to do so, both if you're taking the mono product or the combined product. And then prior to considering discontinuation, you need to make sure that this patient is going to be able to be successful when they come off the medication. A lot of times these medications are safety nets, right? They're just there while the person is learning how to deal with their opiate use disorder. So building coping skills, building a supportive network of people, right? If you start to take away the medication and they have no other contingency plan in place, more than likely they're going to relapse, right? And it's not going to be great. So that kind of wraps up anything. Left a little bit of time for questions. So I work at the Addiction Alliance of Georgia. It's a partnership between Emory and Hazelton Betty Ford, which is the nation's largest nonprofit addiction treatment center. It's a pretty cool collaboration. They haven't really collaborated with an academic program like Emory before. So the things that we're learning by working together are amazing. If you ever have a patient that you want to refer, we do telehealth appointments, we do in-person appointments. We are physically located in Atlanta, but there's our contact information and our website. Awesome. Thank you, guys. Yeah, Dr. Perry.
I've got a question. Thank you. Great talk and very, very timely. Starting this year, our patients who are covered by Medicaid are going to be able to enjoy 12 months of covered postpartum care. One of the key places we're hoping that makes the most difference is with mental health care. What are the ways that we can help them access care? Are there enough providers who accept Medicaid, who will see our patients? How do we find these providers? We would love advice.
Yeah, I think that's always been a challenge, right? So it's not a new challenge. I think it's awesome to hear. 12 months is a pretty substantial amount of time, and you can make a big difference in 12 months. So one thing I would recommend, right? So yeah, we're a resource, and we do accept Medicaid. So you can always, send your patients to us. We do outpatient care, counseling. We have an intensive outpatient program now, and other things. For people who are maybe too far removed from Atlanta, SAMHSA, SAMSHA, does provide this website called Find Treatment Now. It's a little bit more geared towards finding addiction or substance use treatment, but it also helps with mental health connections. I think there is a big deficiency and a gap in people that take Medicare and Medicaid specifically. And unfortunately, I hope that, with more people being able and being eligible for it, providers will start to open up doors, right, and say, okay, there is a need for this, and it makes sense. A lot of these decisions are probably financially driven, right? But, if there's enough need for it and a desire for it, that can influence a lot of what these providers are willing to accept. Awesome. Any other questions? No. Okay. Perfect. Well, if you forget anything, feel free to reach out to me. We can go through it one-on-one.